Welcome back, everyone, to our last session for today. In this session, we'll be focusing on psychological care. Our first talk will be given by Dr. Jairam Kamala Ramakrishnan on practical aids to psychological distress in palliative care. Dr. Jairam is a psychiatrist with an interest in public health and palliative care. He divides his time between clinical psychiatry in locum roles and mental health work in the humanitarian setting. He also pursues teaching and research activities in psychiatry and palliative care. Dr. Jairam is currently a locum consultant psychiatrist in UK and New Zealand. He's also an honorary consultant at the Institute of Palliative Medicine in Kerala, an honorary senior lecturer in psychological medicine at University of Auckland, New Zealand, and he's also a psychiatrist on short-term humanitarian assignments with Médecins Sans Frontières. I hope I pronounced that correctly. He just came back from Myanmar for a humanitarian project that he's involved with there. So for this session, Dr. Jairam will be taking questions right after his talk. So feel free to enter your questions in the comments or Q&A box as we go along. Welcome to the stage, Dr. Jairam.
Thank you for inviting me to speak at this conference. I will be taking you through a very basic overview of psychological distress in palliative care. These are my affiliations. The objectives that I have for the session is firstly to demystify psychological, that we understand some of the basic terminologies which are used in psychological assessment. Secondly, is for you to have some practical things you can try in working with your patients. These will cover practical tips to firstly understanding and making sense of psychological distress, and also a couple of things to try to help people experiencing psychological distress, and most importantly, knowing when to refer or seek help. I hope that you will walk away from the session with a curiosity without fear to explore psychological issues. So, regarding demystification, let me start with psychological and psychosocial. These terms are often used interchangeably. Why is this so? Psyche means soul or mind in Greek and Latin, which is to do with our internal world. Social is derived from socius, meaning companion or associate, everything to do with our external world. Why are these terms combined? Let's see. This slide is a bit full of pictures, but let me take you through it. There are two pictures on the left. You can see that the girl sitting alone is probably a bit lonely or sad. It can make it difficult for that girl to jump in and interact with a group. Also, the other way around, it may be that she was not able to be part of the group socially, which has affected her emotionally, making her feel a bit down. On the right side, the two pictures show you a boy who looks happy emotionally and is maybe going to join the group. Or is he happy internally because the group externally has invited him? Essentially, what I'm saying is that social factors have an impact on our emotions and vice versa. The term social can sometimes be confusing, so let me clarify. It starts with basic needs such as food, shelter, and clothes, but it expands on to our relationship with other people, us having an income or employment or education. All these are social needs. In our life these days, let's say access to electricity, transport, etc., are also social needs. I want you to briefly think about, is a mobile phone a social need these days? So, in essence, when you think of psychological, you cannot forget the social circumstances. And just to complete the holistic approach, I have placed the bio or physical or biological factors there as well, which can influence the other domains both back and forth. So, how do we approach this big, vast area of psychosocial issues? People often feel that they get lost in it. I would encourage you to hold on to this pyramid model. It shows you the scale of the problem. On the left side is a pyramid of morbidity or prevalence, and on the right side is a pyramid for interventions. Each section of the pyramid indicates roughly the proportion of people who experience the different levels of distress. Watch the arrow going up on the left, which shows increasing symptoms and increasing dysfunction. So, the top of the pyramid is where you might need a mental health professional. All the others below can be met without a specialist. So if you look at the basic blocks, which is the biggest chunk of the population, who covers the first basic needs? In most high-income contexts, there are government agencies such as social welfare or social services department which addresses this. However, in a lot of places in Asia, the role of government is limited, and this need is addressed through a mix of altruistic individuals in the community, NGOs, religious institutions, some governmental social assistance, etc. So this means that often in our context, healthcare workers are drawn into addressing the base of the pyramid, and this can be exhausting when people are trying to focus on medical care. So to recap on this section, I hope it is clear why psycho and social are considered together, and also why you cannot prioritize psychological intervention when basic social needs are not met. In essence, do not offer therapy, psychotherapy, to someone who is homeless and unable to eat a proper meal. That would be trying to build a pyramid upside down. Okay, assuming that we have at least the basic needs met, we will focus on the psychological. My tip for you is to remember just three terms: behavior, emotions, and thoughts. This is your compass, this is your anchor in navigating the psychological domain. So, what do these terms mean? Behavior. This is what you can observe of the patient, even without talking to her. For example, she may be smiling, talking to the medical team, but perhaps appears to be crying when alone. Or maybe she's very quiet and does not talk much. Maybe nods or shakes her head rather than talking. Maybe she looks away and does not make any eye contact. You may also get reports on patients' behavior from family members. So, in essence, things that you can just look and see in the patient as a behavior part. The next is emotions. This is fairly straightforward. You need to be familiar with the terms for emotions in your language and use them. You can see the variety of the main emotions, which includes anger, sadness, fear, and joy. Make sure that you know the terms for these in your own language that you use in consultation. I see that health workers are frequently reluctant to use these terms to explore emotions. Remember that we, the same health workers, have no hesitation in asking someone how many times they passed motion or if they can pass urine. But somehow, even when we're asking such personal questions, we're hesitant to ask about emotions. So, after behavior and emotions, the third is thoughts. This is the internal monologue going on in our minds. Each of us has thoughts in our heads all the time. Often we are not even aware of them. So remember these three terms are your navigation aids in psychology: behavior, emotions, and thoughts. Let us now look at how we actually apply this in practice. The first step is to check that the patient is alert. It might seem obvious, but you cannot explore emotions in a patient who is unconscious or sleeping. Also be aware that if you don't share the language and culture of the patient, this may pose a barrier in your communication. Also be aware of sensory disabilities such as visual or hearing disabilities or other disabilities affecting patient's speech and communication. Make a note to yourself of what you have already observed of the patient's behavior. Going on to making sense of the internal world. In exploring psychological issues, remember the pyramid and start with the social situation. Where does a patient live? Is it a house? Is it a shelter? Is it his own? Is it rented? Who else lives with him? The people around him, including family or carers. Who are the most important people to him? Who does he trust the most? How does he spend his time? Does he sleep? Does he read? Does he have a TV show he watches? Does he use his phone much? Does he have friends who visit? Does he go to the shops or the market maybe? Does he spend time with children, other family? This gives you a feel for the person, the individual behind the symptoms and illness and suffering. If you have not gathered it already by these questions, you can now ask further about how these things have changed at all with the illness. These conversations may provide new sources of social support because often there is a friend or relative or colleague who the patient used to be close to but has lost touch with since being ill. Perhaps re-establishing contact may help his situation. Once we know the social circumstances, we can now move on to asking about emotions. There is no way around it. Ask directly about emotions. Let me remind you again that we routinely and shamelessly ask people about their bowel and bladder habits. So why not emotions? You want to find out what emotions she feels mostly and what thoughts she has. What can we ask? I usually ask something like this. For emotions, people go through different emotions all the time: anger, joy, sadness, fears. Since this illness, what emotions have you been feeling mostly? And regarding thoughts, to explore that, a useful way to ask when you have time alone, what do you think about? Or what thoughts fill your mind when you're by yourself? Or you can ask, are there thoughts that keep going through your mind again and again since you've had this illness? So, quickly to recap what we covered so far, remember behavior, emotions, and thoughts. Always start with the social domain and then move to the psychological. Now, how do we try to help with psychological distress? This is the most common beginner's mistake, where we feel that it is for us to give some hope and happiness to the patient. But actually, in order to be effective, that needs to come from within the patient. How do we do it? Find out from the patient what keeps him going through the difficult times. Where does he find the strength? How did he get through the toughest times in his life prior to this illness? Also, find out what brings joy to a patient. When she feels really down or sad or miserable, is there a thought or is there a memory or is there something that she does which makes her smile or feel calm? This could be a memory from her own past, or it could be something as simple as perhaps a movie scene that makes her laugh every time. For some patients with parents, it could be when the baby was born. It could be anything, but it is usually unique to that individual. Next, we make sure that talking about these things are not actually making the patient feel worse. I often ask a patient also, is there anything I could possibly do which could help when you're feeling really down? Or I could ask something like, is there anything that your family or friends do which makes you feel better? So, the take home point in helping with psychological distress is that the source for relief comes from within the patient. Your role is to help the patient find it. Many of the medical staff in this audience might realize that it's a basic trick in medicine. You're basically treating distress as any symptom, and you are identifying, exacerbating, and relieving factors in order to try to manage the symptom. So that's what you're doing when you're asking, is there anything which makes this distress worse, or is there anything which makes this distress better? And you use that in order to facilitate managing that distress. Next, let us look at when to refer to a mental health professional. There are two situations. One is where the person is experiencing normal emotions such as sadness or anxiety or anger, but which appears to go on forever or is extremely intense. A typical example is a patient who responds that there is nothing that changes the sadness they feel, or that they feel anxious or angry all the time, no matter what anyone around does, or no matter what they themselves do. They always feel the same. The other is also if there are any suicidal thoughts. That's when you need to think about referral. The second situation to consider referral is when you see something which you think is abnormal in some way about a patient's behavior. So, typical things include a patient talking by themselves or talking in a confused manner or nonsensical in speech. They may start to hear or see things that other people cannot, what we would call as hallucinations. Or they may have strange beliefs that people are trying to kill them or poison them, etc. So now the question is, once you decide that it is normal, how can you be sure? My advice is to ask the three wise people. Firstly, ask the patient. Secondly, ask the family. And thirdly, ask your colleagues or MDT. If two out of the three think that it might actually be abnormal, that's when you should consider a referral. You should get on the phone to your friendly neighborhood mental health expert. Make sure that you have a mental health professional that you could discuss or talk to informally just to check out whether a referral might be appropriate. Now, some people find that it's difficult for them to ask about these abnormalities. What I typically do is if I see something such as patient is um, behaving in an abnormal manner, say they are talking by themselves or they're talking to someone even when there isn't anyone, I might ask the patient something like, "Look, I'm a little bit worried when I saw you this morning. I saw that you were talking, but I couldn't see anyone else around. I wondered what was going on for you." Or I might ask the family member that, I noticed that this person was sitting and talking by themselves. Is this something that they do usually, or is this something that you think is not normal for them? So the sort of questions posed as someone who's curious but interested in the patient can tease out whether what you think is abnormal is actually considered abnormal by the patient or the family. And obviously, talk to your colleagues within the MDT who might also be seeing the patients to get their view whether something that you observed is abnormal. So, with that, we wrap up. If there is any questions, we can go on to the discussion part. Thank you. Happy to take any questions and discussion.
Thank you, Dr. Jairam, for that really insightful. I think the some of those things perhaps we do uh, naturally in our daily work, but I can see that what you're highlighting there, or perhaps maybe if some of us are not quite familiar, is that it's important to ask the right questions in the right manner, and in to be able to get through to the crux of the issue, the problem, the underlying struggles or thoughts and emotions that a person is going through. We do have a question here from Catherine. She mentioned about your statement that one should not offer psychological therapy when basic needs are not met. Can you take us through the consequences if we don't do this? We do the opposite.
Yes. So it's, I guess it's a bit like any kind of symptom management in palliative care. So if the patient complains of saying, I've got really, really severe vomiting, and you say that, but don't worry, I've got morphine, it'll get your pain better. So it's a little bit like that. If the patient is actually saying that, look, I just want to get rid of my negative thoughts or my anxieties, then by all means, even if the person is homeless and doesn't have food to eat, yes, provide them that psychological support. But If the patient prioritizes their social needs as the first and foremost, unless you are on the same page, you disengage the patient. They don't have any trust in you because they are expressing their primary need and you're not paying any attention to that and you're looking at something else. It's okay to say that, look, I understand that you're struggling with your food, your accommodation, and things. It's not something that I personally may be able to meet, but I can look around, ask around, and try to see if there's any other organizations or people who might be able to help. But I recognize that as your primary issue currently. And then we can go on to look at other needs. It's just about trying to bring the agenda of the patient as close as possible to your agenda.
Okay,
Because
that
otherwise,
makes sense. Yeah, that makes sense because I was just thinking, in reality, we may not be able to solve the issue that they're struggling with, there's no food on the table, or whatever that current issue is. But like you said, it's about validating that, I hear you. This is your main problem right now, and then at least they feel heard. They feel that whatever is the big problem there, obviously there's other layers to explore. But I think it's interesting how you put it in that, yeah, if they're vomiting and you treat something else, then you don't solve the issue. There's also another question from Dr. Zainuddin. When a person is consistently thinking or responding negatively, how do we motivate them to think positively?
yeah. This is again one of the things I said, that that's one of the beginners' concern and things which leads to a lot of people getting burnt out, is that we somehow feel that it's something that we have to provide as an external motivator to lift the person out of their negativity. But in a sense, if the person is not able to think of or to even imagine a single happy thought or a single positive moment in their life when they think back about their own life, then that's a time you probably need to think of referring to a specialist. Because how much of a positive things that you point out to the patient, saying that, look, okay, some people typically say that, look, you have your children, you have such and such things, you have these things, which is good that you should think about. But unless it is actually a positive thought within the patient, no matter how many thoughts you give, it will not stick. And for a person who is consistently feeling so negative, it is important that you seek some help from a mental health specialist. If you ask the patient that, can you think of a single moment in your entire life where you smiled or you felt really happy, and the person is not able to come up with an answer for that, then yes, that is something where you should consider a referral to a mental health specialist, because that's a very good indicator of severe depression.
That's fantastic. I think one of the limitations that we have here in the Malaysian setting is that many of the times we are everyone, meaning that you're the doctor, you're the nurse, you're the physio, you're the counselor, all in one. Because maybe we don't have the resources for a proper multidisciplinary team. But what you're highlighting here is that maybe when we hit a wall, or when we feel that we've done what we can within our capacity, it's important to involve other healthcare members, perhaps a counselor, a psychologist, a psychiatrist. Perhaps it's the limit of our ability to assist this patient, but does not mean that there are not other people that can help. So that's really helpful as well. Okay,
Just
I do.
to add
Yes.
on to that, sometimes people also try to keep going through that a talk session with a patient and find that the patient feels a little bit better, and they keep going on with that, but realize that each time they go to see the patient, it's the same state of mind that they're dealing with, and that can get the health worker or the volunteers exhausted very quickly. So it's very useful to just put it back to the patient, saying that, I recall that previously we talked about this and you seem to feel a little bit better. But to me, it seems that even though we keep talking about this, it doesn't make much of a difference to how you feel. So if that is the case, then it's almost telling you that intervention is not working. So we need to think of something else.
Yes, I agree with you. I think sometimes, one of the purposes of the healthcare work is actually to hold space, for that person, and sometimes it can take a toll if you're not getting anywhere. It takes a toll on the health worker, and then that then has a negative, there's sometimes yeah, transference and counter transference, and um, that then negatively affects the healthcare worker and patient relationship as well. Thank you very much, Dr. Jairam, for that. That was a very interesting talk, and obviously very practical in our daily work. Um, there is actually another question in the comment, but I'm not sure I can take that for now. If you don't mind, would you be able to answer that question in the comment box, and we will move on to the next session. But thank you so much for your time and for being here today with us.
You're welcome. I'll respond to that comment in the chat box.
Thank you.